So now I welcome upon Dr. Agnivesh Tikoo for his lecture on decompression and fusion is superior in long term.
It is said that if you wish to spoil your surgical outcome, just follow up the patient a little bit more longer, and you will come to know that whatever you have done, is it holding true or not. So this is a 64-year-old female, low back pain, claudication and leg pain with a failed management for last 4 months. These are her x-rays. Can I just have a show of hand from the audience and the chairpersons that how many of you would fuse it and how many of you would not fuse it, means just decompression. So fusion and just decompression. So more in this thing of fusion. So another case, 67-year-old male, low back pain with left leg radiation, predominantly leg pain, and these are his flexion extension x-rays. Now, just a show of hand again, how many of you would only do a microdiscectomy or a decompression? And how many of you would fuse this patient? So, none. So, whenever we are talked about a debate in spine surgery, this is what the audience expects. But unfortunately, what spine teaches us is humility, and it tells us to understand a perspective from the other side, because both of the persons may be true. Why fix and fuse? We have to think about the financial implication to the patient for the fusion, longer stay, implant cost, and versus patient outcome. Will I be doing more harm if I'm not fusing, or will I be doing good? When we were given this opportunity by ASSI to write a monogram chapter on role of spinal fusion in lumbar spinal stenosis, we did a long research to find out the indications. And we found out instability, young patient with a constitutionally narrow canal, approach to pathology, where you are looking for your decompression. Is it central? Is it foraminal? Is it extraforaminal? Iatrogenic, if you have resected more facets or you expect that you're going to resect more than 50% or 2/3 of the facet or pars. If it's a revision surgery, if you're looking for correction of deformity in the coronal plane apart from the decompression, if it's an adjacent segment disease, if it's a facetal cyst, or you're looking for indirect decompression, then you need to consider fusion as one of the options. So this is a patient, very active, healthy male, and has been operated twice for claudication and leg pain, but again failed. These are the MRI, still shows lateral stenosis, and this is the X-ray. So this patient is not going to get benefit by a third time decompression. Here you have to look at fusion, and you have to correct and stabilize this patient along with the revision decompression. Another 60-year-old male underwent a minimal invasive transforaminal lumbar interbody fusion and now has developed adjacent segment after 5 years. And this patient, if you are looking for extension, we have to fuse this patient. You cannot just do a sole decompression in this patient because already the cause is instability. So in this case, we removed the lower screws because the disc was well fused, and we just extended the fusion upwards, and this was also done minimal invasively. Approach to pathology. So this is a patient of acute intractable right leg pain, chronic pain. Both of the foramen are showing calcified hard discs, and there are multiple dural calcifications which are seen. So this patient, we have to do a complete resection of facets and go extra wide, find out that calcified disc, detach it from there, and go along the route extraforaminally, ensure that it is decompressed well, and then you need to add a fusion because your approach destabilized this patient. Another patient where you're looking for correction of deformity, a very bad degenerative scoliosis and having severe pain going kyphotic at dorsolumbar junction. And this patient, when was positioned on the operative table, everything opened up and there was a big vacuum ahead of it. So you're not going to leave this patient without a fixation. And this is what we had to do, and you can see the post-operative result with a relatively good coronal alignment now. So literature can guide us either way. There are three types of lies. One are lies. the second one are damn lies, and third one is statistics. So you can tweak the data in any way to suit your need. You can decide whatever you want to churn out from that data. Our biggest example is the NASIS trial from our thing, where you did not get anything, but you made it a post hoc analysis and you found out something from it, which we are still struggling to do. Now, this is a meta-analysis of secondary fusion rates following open versus minimal invasive decompression. The presence of this meta-analysis in literature itself says that you have to carefully look at fusion rates after your decompression. Otherwise, this meta-analysis would not have existed in its first place. Another thing where meta-analysis was done, secondary fusion rates, one major important thing was that there was significant differences noted regarding the distribution of intraoperative and early postoperative complication among 6 main surgeons. So it is the surgeon also where it matters what he is deciding to do with the patient. And regarding the adjacent segment for the fusion patients, most of these adjacent segments are radiological and they are not clinical. Means you may see a X-ray where there is subtle listhesis. You may see a X-ray where there is some degeneration at the upper level. Patient has mild pain. But believe me, most of these settle if you treat them conservatively. So we are looking at a clinical ASD of 5% and not a radiological ASD. Well, this brings me to the point that this we were 1 week ago, where Raghu sir was sort of proactively advocating fusion because he was in a session of fusion just 1 week ago. But knowing him from all these years, I know he's a saint who has been given the wrong side, or maybe the other side, but he won't do anything wrong to his patients. He will follow the dharma. So I'll come back to the cases which I showed you in the beginning. So this patient had a CKD, was on hemodialysis, hypertension, diabetic, low demand lady. This is what I did. She just settled with a root block, no decompression, no fusion, nothing. And the second case where all of us agreed that we did not do a fusion, this is what I did. And 3 months back, patient came with, out of blue, came from this with a facetal cyst with new symptoms. And then I had to do a fusion surgery in this. So that's why I said spine teaches us humility and wants us to sort of understand the perspective. And to conclude, I would like to say the problem with the world is that the intelligent people are full of doubts, and while the other half is full of confidence. And lastly, that don't go to Chris Martin because he's bound to fix you. Thank you so much.